Kia ora. My name is Alex Hussey. I'm a paediatric intensivist in New Zealand. I'd like to introduce the World PICU Awareness Week talks for the Oceania region. Oceania is a region that encompasses Australia, New Zealand, and the Pacific Islands. To open this meeting, firstly, a welcome to country for Australia. In the spirit of reconciliation, the World Federation of Paediatric Intensive and Critical Care Societies acknowledges the traditional custodians of country throughout Australia and their connections to land, sea, and community. We pay our respect to their elders past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. Secondly, a karakia, or greeting prayer for New Zealand, given in Te Reo, the language of the Maori people. E te hui, whai te mataranga kia marama, kia whai, ne mahi katoa, tu maya, tu kaha, aroa atu, aroa me, tatu ia, tatu katoa. The first presentation is entitled Aotearoa, Inequality and the Whānau. I'm going to set some of the background to New Zealand, how to understand the concept of family or whānau in Te Reo, the language of the Maori people. Here we need to talk about New Zealand as a country, its ethnic structure and challenges, and the traditional concepts of what whānau actually means. Aotearoa, or New Zealand, is a country in the southwest Pacific Ocean, approximately 2,000 kilometers east of Australia across the Tasman Sea. It consists of two main land masses, the North Island and the South Island, and over 700 smaller islands as well. It has a population of 5.1 million, with Wellington as the capital at the bottom of the North Island. However, Auckland at the top of the North Island is the most populous city, which accounts for a third of the population. New Zealand is a very beautiful and varied country, often advertised very nicely in Hollywood movies. It's also well known for its friendly people who embrace the outdoor lifestyle, and their very successful rugby union team, the All Blacks. However, like most countries, if you scratch beneath the surface, you find there are challenges and issues with inequality. In the most recent census in New Zealand in 2018, New Zealand's cultural makeup is becoming more diverse due to high population growth in the past 5 years. Growth in overseas born population is what's driving this. The issues with this are newcomers are not familiar with the New Zealand health and disability system, as well as social or legal systems. Health providers experience difficulties with language, experience, culture, and belief differences. And there's a growing pressure on the health service just due to overwhelm from the sheer numbers. New Zealand has a single dedicated paediatric intensive care unit that covers the whole country. This consists of just 16 intensive care beds and 6 high dependency beds. Thankfully, it is going to be expanded soon. It is a combined cardiac and general intensive care unit. Due to the limitations of resources, some paediatric patients have to be managed by adult intensive care units around the rest of the country, awaiting for either their illness to recover or the transport team to arrive. The unit admits approximately 1,100 patients per year, and these are children up to 15 years of age. 45% of admissions are cardiac cases. 50% live outside the Auckland region, and with ethnic breakdown, 35% are defined as New Zealand European, 28% as Maori, 18% are Pacific Islanders. There's a dedicated retrieval service which is incorporated into the unit, which covers the whole country and occasional flights to the South Pacific region. They perform approximately 300 retrievals per year. This bar chart provides very surprising information. It describes the bed days by ethnicity for the 4th quartile in 2021. Despite New Zealand European being the predominant ethnic group in the country, the bed days is heavily weighted towards New Zealand Maori. This represents greater illness severity or complexity in this population group. It's important to understand the socio-political structure of New Zealand, as it is the main basis for government health policy. The Treaty of Oceania is of central importance to the country's history and political constitution. In 1840, this was signed between the British Crown and the Maori chiefs. It was planned to affirm Maori sovereignty and formalise the agreement that the Crown would protect Maori authority over their land and treasures, including their health, and also to recognise equity with the British peoples. However, this does not plan out as expected. It is still controversial and heavily contested. Successive governments have taken action, resulting in the loss of Maori land and language, and the decline of the Maori economic, social, and cultural well-being. This has led to a significant distrust and persistent inequity. Looking at inequality, some level of inequality is unavoidable in societies. It often becomes a significant issue and often associated with poor long-term social outcomes. We're just going to cover financial and health inequality in this presentation. It's important to recognise that similar patterns are seen between indigenous and non-indigenous populations in many countries around the world. The figure on the left compares household net worth against income by quintile during 2018. In New Zealand, 70% of household wealth was held just by 20% of households. The first quintile, i.e. the lowest level of wealth distribution, here the average household had negative net worth. This means that it had more liabilities than assets. There is some regional distribution of this discrepancy as well, shown on the map on the right, where green and blue coloured regions have negative net worth. These tend to be in regions outside the main cities, but also regions with less non-New Zealand European home ownership. There are also areas more remote from health services too because of this. Maori and Pacific children more likely to live in households with low income or material hardship compared to New Zealand European children. New Zealand's health system is based on the UK's National Health Service. In fact, it's 10 years older than the National Health Service. Most healthcare is financed by the government through tax payments. GP visits for those over 13 years of age are subsidised. There's now also a no-fault accident compensation scheme known as ACC. There is also some private healthcare, which is increasing due to strains on the public health system. Health inequalities between Maori and non-Maori New Zealanders are large and pervasive. They persist across lifespan, over time, and surpass inequities by deprivation and geography. The Maori society is built around the concept of whānau and whakapapa. The literal English translation of whānau is family. In Maori society, family is not the nuclear family that Western society defines. It is a collective of people connected through a common ancestor. Each member of the whānau is supported by the other members and are united as one. Knowledge and resources are shared within the whānau to empower each other and overcome issues with greater support. There is no feeling of isolation within a whānau. Whakapapa is a fundamental principle of Maori culture. It is a deep connection to the land and the roots of one's ancestry. At Starship Children's Hospital, whānau-centred care is the priority. We recognise the importance of our relationship with the whānau in patient management. This is achieved through a number of ways, as described on this slide. Whānau can visit patients anytime and can be present on the ward rounds. They have designated whānau rooms outside the unit to congregate. When the medical staff meet the whānau, they follow the hui process. This is a structured meeting respecting Maori culture. We have a strong presence of social workers on the unit and a vital long-term patient specialist nurse who you're going to meet soon. The consult liaison team provides psychological support to whānau and patients. We have weekly long-term patient meetings and weekly multidisciplinary team meetings. There is a strong cultural support and safety ethos within the whole hospital. The Mehana model is a clinical assessment tool that has whānau centred at the heart of the assessment and intervention processes. This is fundamentally Maori, where the patient is not an individual but part of a collective. The model revolves around the waka, the traditional double-hulled voyaging canoe used by the Maori. The model uses 5 crossbars of the waka. And these create the connection between the patient and the whānau. They consist of physical well-being, consciousness and awareness, access to quality health services, spiritual well-being, environmental well-being. Ngāho e whā represent the four winds of the Tāwhiri Matea. These are shown either side of the waka. This identifies components that reflect both the historical and current societal influences of Māori as indigenous people of Aotearoa. There are four influential interrelated winds are known as colonisation, racism, migration, and marginalisation. Ngā moana represent the four ocean currents depicted at the bottom of the picture. This identifies specific components for Māori worldview. These are personalised indicators, Māori cultural principles, whānau, and also whenua, which is the specific genealogical or spiritual connection between the patient and the land. And lastly, whakatere is the navigation or sails, and this draws together the relevant information, integrates information within formulation, diagnosis, treatment, and processes. Also challenges and supports clinicians to acknowledge and mitigate personal and institutional biases within assessment, formulation, and treatment. There's so much we can learn from the concept of whānau for Māori culture and how its rich concepts can help us look after our patients more effectively. The next presentation is by my colleague, Teresa Campbell. Thank you.
Hi, my name's Teresa and I'm the Clinical Nurse Specialist, Long-Term Care Coordinator for PICU at Starship Child Health, the National Dedicated Children's Hospital for New Zealand. I would like to share with you my role and how we support whānau through the journeys of PICU. Often thought as a small country hiding at the bottom of the world, New Zealand has a land area 10% larger than that of the UK. And when juxtaposed over Europe, New Zealand's length actually covers the distance from North Copenhagen to southern France. As Alex has already shared, and despite New Zealand's size, it has only one dedicated PICU. This is located in Auckland at Starship Child Health. The result in our patients being transferred to us from the length and breadth of New Zealand. In 2021, 50% of patients and their families admitted to PICU lived outside the Auckland City region. When you look at New Zealand and its long, narrow geographical shape, this can result in some patients and families being significantly displaced from their home, family, community, and support systems. My role as Clinical Nurse Specialist is to work within the Starship Nurse Specialist Care Coordination Framework. This framework recognises that paediatric care coordination is a patient and whānau-centred assessment driven and a team-based activity designed to meet the needs of the children and youth while also enhancing the caregiver capacities of whānau. Care coordination addresses interrelated medical, social, developmental, behavioural, educational, and financial needs to achieve optimal health and wellness outcomes. The intention of this role is also to reduce fragmentation and improve the child, young person, and family experience of our service. In 2021, the median stay for PICU was 1.4 days. But in 2021, 6% of our total admissions were with us for greater than 2 weeks. It is these children with complex, longer-term PICU care needs that come under my scope of care, and I'm able to care coordinate. The goals of care coordination are better family and patient experience, improved care with MDT involvement, communication and handovers, family-centred care coordination, integrating services, understanding of family needs by healthcare workers, discharge on expected discharge date, a decrease in readmissions, and improved health outcomes and quality of life. It is fundamental that when we as a service look at our delivery of care for our patients, that we also recognise our cultural and ethnic backgrounds. The Māori are the indigenous people of Aotearoa, New Zealand. There are aspects of Māori culture that other New Zealanders relate well with. The Māori culture has a very holistic approach to well-being. The Te Whara Tapa Wha is a model that illustrates the 4 dimensions of Māori well-being. With its strong foundations of whenua, your land, place or roots, and its 4 equal sides. The 4 dimensions are Tāna Tihana, it is your physical well-being. It is about how your body grows, feels and moves. It's how you care for it. Taha Wairua, your spiritual well-being. It is your spiritual essence. It is your life force. This is who you are. It is what you are. It is where you come from. It is where you're going. Taha Hininauro, your mental and emotional well-being. It is your mind, heart, conscience, thoughts and feelings. It is about how you feel as well as how you communicate and think. And taha whānau, it is your family, your social connections. It is about who makes you feel like you belong, who you care about and who you share your life with. Should one of the 4 dimensions be missing or in some way damaged, a person or a collective may become unbalanced and subsequently unwell. The simple process of a child or family being admitted to hospital away from their whenua or their whānau can unbalance a person's well-being. In providing care and support for children and their families in PICU, it is important that we recognise this model of well-being and help keep these foundations and dimensions strong. In 2021, Māori made up for 30% of admits to PICU, but when broken down to number of bed days, they made up over 40% of these. This high percentage of bed days highlights the reason for admission was often more complex healthcare needs requiring higher level of care for a longer duration. Whānau is a concept that applies to many cultures and ethnicities. Whānau is about who makes you feel like you belong, who you care about and who you share your life with. Whānau is about extended relationships. It's not just your immediate relatives, it's your friends, colleagues, community, and the people you care about. Everyone has a place and a role to fulfill within their whānau, and whānau contribute to your individual well-being and identity. While generally referred to as family, these relationships are not necessarily reliant on kinship ties. Whānau is recognised as the foundations of Māori society, as a principal source of strength, support, security, and identity. Whānau plays a central role in the well-being of Māori individually and collectively. I would like to share with you one of my patients. Jack is a 15-month-old boy who has spent the last year as a patient in PICU due to complex airway issues and ventilation dependency. During this time, we have not only cared for his medical needs, but as a team prioritised his whānau needs and support systems, particularly recognising that Jack and his whānau are separated away from their whenua, their land, roots and whānau. Jack has 2 older siblings who are school-aged, and while he's at the start of their admission, they were supported on site at the Ronald McDonald School and our PICU play therapist. This year, we have supported these siblings to being enrolled at local schools to create more normality and routine. While at Starship, Jack's family, like many others, stay at the Ronald McDonald House. The MDT team at Starship spend their time working along Jack's family, providing education about his healthcare needs and education about his medical devices. Jack has embarked on the long-term ventilation pathway, which has a care package and education resources to assist the whānau in achieving confidence and providing the necessary care for the child at home or in the community. Jack's family are also supported by our social work and consult liaison team. And Jack's family are supported by the play therapists. They are there to help guide his developmental learning needs and educate his family how to cater for his developmental needs alongside of his medical needs. When I asked Jack's mum about how she felt we supported her in her whānau, her response was, "The biggest support the PICU team gives me is the understanding I can't be everywhere at one time. They support me to be at the bedside with Jack, but also recognise and support me to be away from Jack and looking after myself and my other children. Our goals as a team are to work in partnership with whānau, share information and decision making, and have a mutual goal setting. Being a long-term patient in PICU creates challenges for whānau. As previously highlighted, one of the biggest challenges for PICU long-term whānau is their isolation and displacement from their community and support systems. Long-term families often experience financial problems or pressures, where money can cause extreme stresses. Parents express financial difficulties were due to not working because of being described as being in the PICU with their child as a full-time job. As Jack's family has expressed, families often feel challenged with the demands in and out of hospital. Parents feel shattered by being pulled apart between the worlds of hospital, work, and home. In recent times, COVID restrictions have also hugely impacted families and their stay in PICU. While previously, Starship PICU had an open visiting policy where families came and went from the bedside into our whānau space, in the more recent times, strict lockdowns have meant only 2 nominated visitors per person. This has once again increased isolation and removal of whānau support systems and placed a further strain on families and relationships. Hospitals can be anxiety-producing environments with unfamiliar routines, practices, encounters that at times can be intimidating, strange, or intrusive. How do we overcome these challenges? It's important that we talk to families and patients, not around them, using their names. It's important that we listen and ask, explore, don't explain. It's important that we hold informal and formal meetings to keep everyone up to date. It's important that we follow through with what we're going to say we do. Trust is essential, but can't be assumed. It's important that we outline expectations of the healthcare setting up front. We should prepare families for differences so they don't get surprises. Expectations are not always met, but if whānau are prepared for these differences, their ability to manage it often results in a more positive perception of the situation. It's important that we're compassionate. Get families involved, and if a child is old enough, get them involved with their care too. Above all, communication is the key to overcome challenges. Kia ora, and thank you very much for listening and watching from around the world.
In the spirit of reconciliation, and given that we are all attending from different locations today, I would like to start off my presentation by acknowledging the traditional custodians of country throughout Australia and their connections to land, sea, and community. I wish to pay my respect to elders past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples today, acknowledging and upholding their continuing relationship to this land. My name is Tara Jane Clark, and I have the privilege of being the psychologist in the Royal Children's Hospital's Paediatric Intensive Care Unit. I want to thank the World PICU Awareness Week's Organising Committee for the opportunity to speak to you about a topic that I'm really passionate about, supporting the mental health of our PICU community, and that's inclusive of our patients, families, and the staff that surround them. I would also like to extend my thanks to you for taking the time out of your busy schedules to prioritise this webinar in your pursuit of improving care for the children and families that you work with. In acknowledgement of this year's theme of family in the PICU, I will be talking about how we've set up an embedded psychology service on our unit. I'd like to start with some history of the project to give some context to the role or service. Under the PICU leadership team and project management of Priscilla Stevenson, RCH PICU applied for funding for a pilot project to introduce an in-house psychologist to provide services to patients, their families, and also to staff. It should be noted that access to mental health is integral to the holistic care of RCH's patients, and up to this point, mental health was accessible to our patients via our hospital-wide consultation and liaison service. However, this initiative would mean that our unit had a dedicated clinician. Funding was successful, and at the start of the project, there was a dedicated patient and family psychologist, myself, and a separate psychologist assisting with staff mental health, my wonderful colleague, Sukwan Lee. In addition, we were lucky to have a project manager assigned to the pilot, so I'd like to acknowledge Kate Masterson, an amazing nurse and researcher who was in that role. Following a successful 18-month pilot and the departure of my colleague, the positions were combined into one full-time position. With some learnings gathered from the initial pilot, that there was a sense that staff benefited from working with a clinician that was also embedded in the day-to-day clinical care of patients. March 2022 will be the 1-year anniversary of the combined roles, with embedded psychology being in the unit for 3 years in June of this year. The historical context is important to consider in regards to the role of psychology in PICU, specifically in relation to the wealth of psychosocial services that already exist. RCH is privileged to have a number of dedicated clinicians who provide care aimed to improve the quality of life of patients during their hospitalisation, and therefore introducing a new psychology service needed to be mindful of the significant overlap of clinicians. While the goal of a new service should be to provide benefit to patients and families, it was also important to consider the potential burden of more people being involved in care. Therefore, collegial relationship building and consultation has been a foundational aspect of setting up the service. So why does PICU need a psychologist? We know an admission to the PICU environment has its unique stresses, including, but not limited to, the acuity of the medical situation. So that might be in the context of a family's first admission to hospital following a trauma, or on the other end of the spectrum, a deterioration in a long-term chronic condition for a family that would consider themselves quite healthcare savvy. The altered physical appearance and behaviour. So we can become quite immune to the shock of seeing a child with a tube down their throat or laying in a bed with their chest open. But understandably, these are significant stresses for parents. Additionally, delirium is in the realm of our day-to-day work, but seeing your child reacting to non-apparent stimuli or just not acting themselves can be incredibly scary. We have families who come to us from around the country, so they're dislocated from their homes and their supports. And you know what's best at the end of a long, stressful day? Getting in your own bed with your own pillow. These families don't have those creature comforts that we take for granted for extended periods of time. There's a disruption to their role as parents. And while parents are very complementary to the care their child receives, they're also very mindful of losing their role and can feel useless at the bedside. Alongside feelings of societal pressure that they need to stay there for long periods of time in case they're perceived as bad parents. And us, we can be stressors for parents. Again, despite our best intentions, sometimes we're the source of stress with a lack of clarity in our communication between and within teams, and subsequently how we pass that on to families. An admission to PICU causes high levels of distress for patients, particularly those who experience longer stays. And we know this is becoming the norm for our patients staying longer and getting more complex without a real substantial change to the psychosocial model of care we provide. We know research suggests that families experience more intense distress and trauma symptoms than those on general wards. One of the most consistent findings of the research is the importance of parental perception. The sickest child does not correlate with the most parental distress or the need for psychosocial support. Subsequently, the PICU psychology service is a referral-based service in that not every family has or needs mental health input, nor would that be feasible. However, in a highly medicalized environment, not having a clear referral criteria has probably been a bit of a stumbling block, leading to blanket referrals across psychosocial services, with staff not being 100% sure who's best placed to support a family. So what is offered to families? So it's really short-term psychological therapy, and that could be around adjustment issues that manifest in anxiety, low mood, sleep disturbance. It might be about providing recommendations about how to discuss the admission or their child's condition in a developmentally appropriate way. It can be about assisting with challenging teams and family dynamics, whether that's being an advocate for the family's voice or that of the staff and the teams. And it might be about liaison. So this might be where there's been a pre-existing mental health concern identified for the patient or parent or sibling, where the current ICU admission impacts their capacity to engage with previously involved services. So we might consult with an external mental health service about previously used strategies and how they might be applied to the current circumstances. And we also provide a longer term input post-discharge or referrals to community services as required. Since the inception of the role in June 2019, there have been 280 referrals to psychology services for PICU patients and or their families, with a wide range of referral numbers per month, ranging from none to 17 and probably averaging at about 8 per month. It should be noted that not all those referrals result in direct contact with families for a number of reasons. For example, after consultation with the referrer, it might have been deemed that that referral wasn't appropriate, or another service may have been better placed to support that family. Irrespective of the outcome, I believe the numbers show that families and staff are able to identify the need for psychological support, and sometimes the psychology role is to help consult or redirect to the appropriate professional. Outside of the referrals for direct psychological support, we've trialled a number of other interventions. The ones that have probably fallen in the missed category include screening approaches to identify psychosocial risk, and this was problematic in poor return of paper surveys and not really getting traction on group interventions, and this was prior to COVID. While there have been misses previously, I still believe there's a role for psychosocial screening, but potentially in the first instance, the administration of this might sit within the nurse coordinating role for our long-stay patients and their families. One of the emerging interventions is our Little Hearts Round. Alongside our cardiac nurse coordinator, Shani Lowry, we've been endeavouring to have attachment-focused conversations with our cardiac cohort. This resulting in a summary that reinforces for our parents their baby's emerging personality outside of hospitalisation. This has also proved to be a trigger for staff who might enter the room to discuss the baby in a broader context. The role has also had a psychoeducational component, and we've had opportunities to gather as a unit to think about how we engage with families at challenging times, or via our version of a Schwartz round to reflect on topics such as working with culturally and linguistically diverse families, engaging with adolescents, or just as importantly, taking time to reflect on the good work that gets done as our unit in our 2021 year in review. While families have been complimentary of psychology input during their admission, it's been difficult to elicit this feedback formally. However, our wonderful previous project manager, Kate Masterson, was able to establish staff feedback of the service. The most significant theme that emerged for staff was the reduced burden for them. While I don't think that my nursing colleagues give themselves enough credit for psychosocial interventions that they do at the bedside, it appeared that the psychology role allowed nursing to feel that they could focus on their clinical nursing care and responsibilities foremost, knowing that someone else was attending to the mental health care needs of their patients. While this is not in the scope of today's topic, I would like to note the importance of the interplay between patient and family side of the role and that of the staff support side. Last year, there were 171 staff sessions booked. I have the hope that if our staff feel supported psychologically, that this will have a direct payoff to the quality of care that we're able to provide our patients and their families. From an aspirational standpoint, if we aim to provide holistic care to the families that are under our care, we should be doing that for the staff that care for them. In wrapping up, what was the key learning from setting up the service? Well, it's somewhat obvious. Relationships are key. It has been important to acknowledge pre-existing service pathways and consider how a new service complements or complicates the system. While it's been important in reducing duplication of work between healthcare professionals, it's mostly important in its impact on families, in avoiding exposing them to repetitive psychosocial assessments and potentially re-traumatizing them in the retelling. Relationships have also been pivotal in navigating the challenges associated with a lack of clear referral criteria. While it could have been put in the too hard basket, staff feel more comfortable reach out directly to discuss referrals, which anecdotally has reduced duplicate referrals across services. And in reference to the title of this talk today, just popped in for a chat, it was actually one of the comments made by a staff member who felt that the role provided little impact on the ward. So there's also been a lot of work on demystifying mental health. And in relation to this comment, the recognition that a psychologist popping by for just a chat may be a non-intimidating way of connecting or containing and be an intervention in itself. And obviously the relationships built with families are the best advertisement for the service. It has been apparent that staff feel more comfortable making subsequent referrals when they've seen direct benefit to the families that they're also working with. Finally, I would like to thank the families who have given me an insight into their inner worlds in one of the most challenging experiences of their lives. And obviously the service wouldn't work without the referrers or the advocates. So I'd like to thank the hardworking PICU staff who have looked beyond the immediate medical or nursing care needs of the day to be psychosocial champions by raising the idea of psychology input with families. I'll end with a reminder that there's no health without mental health. While I'm very keenly aware that not all units will be in the fortunate position to have an embedded psychology service, we can all play a part in thinking about the psychological impact of a PICU admission on the patients and the families that we work with. And this week, you're doing that by being here. So thank you.
Hello everybody, and thank you for joining me today. I am talking to you about the outback to Brisbane, the challenges of a hospital within a huge catchment. My name is Sophie Weeks and I'm the acute clinical lead for the paediatric social work team, and I'm working alongside Michelle Maunder and Sarah McMahon, who are both senior social workers here in our paediatric intensive care unit. So we thought we'd start off today by showing you the vast expanse of Queensland. And as you can see there, United Kingdom fits quite nicely into Queensland. So we account for about 22.5% of the Australian landmass. It is about 1.7 million square kilometres, which is a very, very long way. There are over 5 million people here in Queensland. We've got major cities, regional centres, as well as remote and very remote areas. Southeast Queensland accounts for about 70% of the total population, and a vast population of our First Nations people actually reside in the regional and remote areas. So we thought we would start off by showing you a picture of our hospital, that is the Queensland Children's Hospital, and we moved here in 2014. So the Queensland Children's Hospital is a specialist statewide hospital and health service dedicated to caring for children and young people from across Queensland, as well as northern New South Wales. We care for the sickest and most seriously injured children, and we partner with regional and remote health services. So the complexities that come from this very large geographical area include the fact that families come with very limited resources and access to healthcare, and that the distance between these areas and Brisbane can take days sometimes to get here, and it can be quite complicated to retrieve a very acute patient. So there's also difficulty in families being able to travel to Brisbane to be able to support their child, and often we do have children here without parents or support people. So that obviously can bring feelings of dislocation, and people sometimes feel quite lost here in the big city. They don't know where they're going. They sometimes have never been to a big city before, so don't even understand practical aspects like crossing busy roads, using lifts, or how to use services, and especially navigating quite a complex medical system. So this can all be quite challenging for our families from these communities. So our First Nations people also experience cultural barriers and challenges such as feelings of shame or embarrassment, and they might feel awkward asking any questions about medical needs that they might not understand. Sometimes they find the medical language quite complex, and I know I certainly do. And if you've come from a community where that is quite different to how you usually live, then of course it will be quite surprising and something very difficult to adjust to. So sometimes families need an advocate for the family system, especially if there are kin who are considered family and that might not usually be allowed in to see family. So also we need to consider there may be previous trauma or previous family members who may have died in a hospital away from their home and away from their community. There's also a fear of being judged. Families often think that they might be judged for not looking after their child. There's also fear of government systems, and that can be historical as well as current. Also, as mentioned before, the travel, the length of time, sometimes it can take people multiple planes, buses and trains to get here from these remote communities. So I guess the other thing that's important to remember is that these families are having to trust in white man's medicine, which might be quite different to what they believe. So we thought we would share with you our current Indigenous health liaison team. We know that families travelling from these remote communities and being away from their families and friends can sometimes find it difficult and lonely and isolating. So we often have to think outside the box and get creative in terms of how we support these families. So at the Queensland Children's Hospital, we obviously have the social work team, as well as welfare, as well as the Indigenous liaison team, as well as nurse navigators. And we can sometimes support with practical needs like travel and accommodation. We sometimes access angel flights to bring families from rural and remote communities. Our welfare team certainly support families with patient travel, which is PTSS. And we sometimes access the Children's Hospital Foundation, who can support us with often unique ways to help families. And of course, our Indigenous team, as you can see there on the screen. And so our Indigenous team can provide cultural care, advice and support. They can help families understand the child's diagnosis or medical procedure or treatment. They can provide support when speaking with doctors or treating health teams. They can ensure that people's voices are heard and that wishes are respected. They can assist in making appointments and hospital routines and planning a child's discharge home from hospital, which can sometimes be challenging again if going back to a rural community. And they can provide information advice about community services. So I thought we would talk a little bit about the social work role, which myself, Sarah and Michelle cover. So social work within the paediatric intensive care unit have a model of care, and we review all patients who come through the unit. We complete psychosocial assessments, and we focus on the family context, stresses, parental coping and adjustment. We use a current statewide assessment pro forma that we've been trained in, and we assess the family context and include aspects of family structure, child protection, domestic and family violence, separated and co-parenting family arrangements, risk assessments, protective factors, health literacy, guardianship, consent and care arrangements, as well as many other things. So we believe that involving social work early aids in normalising the social work support role and encourages rapport building. Assessment of need and coping has been beneficial in managing the admission for both families and for the team. For example, if there's a patient deterioration or a challenging behaviour, if we already know that family, it can certainly make things easier. We believe that social work is integral to the paediatric intensive care unit for family engagement, family meetings, anticipatory grief, end-of-life care and bereavement follow-up, as well as case management of very complex family systems. So as I said earlier, we think it's important to normalise social work involvement in the family care as part of the paediatric intensive care unit team. We can certainly then assist with alerting families and teams if there's any coping issues or concerns or any deterioration or acute health event. So we can also support with practical issues like organising accommodation, especially for these families who come from rural and remote communities. And we can refer to the welfare team or family travel hub. So we thought we would talk a bit today about a case study. I'm going to talk about baby Lily, who was 1 day old when she was admitted to the Queensland Children's Hospital. So at the commencement of Lily's admission, the social worker and the Indigenous Health Liaison Officer focused on utilising organisational supports to make arrangements for Lily's family to travel to Brisbane. So due to the remoteness of Arakoon, which is where they live, and limited resources in that community, it was very difficult to have regular contact with Lily's family. So whilst social work collaborated with health services in Cairns and Arakoon to support telephone and conference calls, discussions with Lily's family and decisions regarding who would travel to Brisbane were unfortunately a bit stilted. And due to a number of cultural barriers, the family ultimately decided that they wouldn't be able to travel to Brisbane, sadly. So by day 12 of Lily's admission, her condition had sadly significantly deteriorated, and it was felt by the treating team that discussions about a paediatric acute resuscitation plan, or PARP as we call them, needed to occur with the family. So given the family had not actually met Lily's treating team or even seen Lily in the 12 days, a decision was made to commence using Microsoft Teams to communicate with the family. During the next 2 weeks, a number of these meetings would occur between the Queensland Children's Hospital Paediatric Intensive Care Unit staff and the family, who were situated still in Arakoon. So whilst logistics for these meetings were difficult to organise, and acknowledging the difficulty of building rapport and having discussions about potential end-of-life decisions isn't the best over video calls, it actually was essential for engaging with the family, and ultimately there were a number of positives for this family. So as you can see in the picture there, she was originally transferred from Cairns Base Hospital in Far North Queensland. So you can see that the distance by car is actually 29 hours to come to Brisbane from Arakoon. So it's a very long way. And it is a very remote Indigenous community in Far North Queensland. So moving forward, the family were able to regularly see Lily over Teams, and they developed a greater understanding for her condition by being able to see the number of medications and life-sustaining supports that she was on. So it also allowed for Lily's whole family to see her and to engage with her, to see the nurses supporting her care, and to meet the Indigenous liaison officer who was providing cultural support to Lily. So our Indigenous officer was very close to Lily and would often spend time with her, cuddling her and talking to family back home. So having these meetings via Teams also allowed for Lily's mother to have the support of her whole family, which helped with feelings of confusion around medical questions, because she had people there to support her and to clarify things for her. It also meant that she had them present for discussions regarding decision making about Lily's care. The whole family were actually able to attend a local health clinic and be involved in these meetings, and the health clinic staff were then able to support the family once the meetings had finished. So I think it was important for them to have those local staff members involved, and they were also able to go out and do home visits and check in with the family. In fact, one of the meetings, it's quite funny in hindsight, but was actually under a tree, which was significant for the team as well as for the family up in Arakoon. So when baby Lily returned to Cairns, we were able to then return her to the community in Arakoon, which was quite incredible considering how far it is to get her home. So the things that we learned from her time here in Brisbane without her family, it was important for us to take some of the small wins. So there were some times that we felt things were quite tricky, such as meetings that weren't successful or the family changing their mind regarding attending Brisbane. So that was quite difficult to establish, because they were coming and they weren't coming. So then it was tricky, like I said earlier, to discuss things like end of life over Teams. But we actually found that it made us more appreciative, as I said, of the small wins, and a good meeting where the family felt actually positive about baby Lily and about the fact that they felt included in all of the medical decision making. So they were very happy that they then got to see Lily over the screen. Some of the family members who may have never come to Brisbane to meet baby Lily got to meet her via Teams, which was very special. And then the biggest win of all, of course, was when baby Lily arrived safely in Cairns with the family wanting to take her home to Arakoon. What we also took from this case was positive learnings about how we can further engage families from across our vast state of Queensland. The challenges of caring for children in rural and remote areas can sometimes feel overwhelming for families and for our staff. However, by accessing all of the supports available and thinking outside of the box, we can ensure that our sickest children and their families have the support that they need to manage and cope during some of their darkest days. And we hope that social work and our Indigenous health liaison team were able to support these families during some of their most difficult decision making, and obviously the planning in terms of getting baby Lily home. So that's the end of our presentation for today. If there's anything further you'd like to know from us here in Brisbane, please feel free to reach out. Thank you again for joining.
Hello, I'm Fenella Gill. I'm a paediatric intensive care nurse and now researcher in Perth Western Australia, and I'm really delighted to be included in the Oceania webinar for World PICU Awareness Week, with the topic being families in the PICU. I'm going to talk about empathic measuring parent experience in the PICU. So just some background to start with. The empathic questionnaire was developed by Jos Latour, who is now a professor at the University of Plymouth, but at the time was based in the Netherlands, where he developed the empathic questionnaire for his PhD. That was an extensive body of work that identified parent satisfaction items from the perspective of parents as well as health professionals in the PICU, and then also in the neonatal intensive care, and then undertook a series of reliability and validity testing, so that produced validated empathic questionnaire, and also a questionnaire for the neonatal intensive care setting. Subsequently, he developed a short version of the empathic questionnaire with 30 items, and then we in Australia have developed the empathic 30 Oz. So the empathic questionnaires overall, so the set of the original empathic, the empathic N and the empathic 30 are being used in up to 40 countries. Many researchers are using the empathic, and some have also validated the questionnaires in different languages. So the original empathic was developed in Dutch, so based in the Netherlands, but has been validated and translated in many other countries, including English, Australian, for our work. So the empathic 30 questionnaire, to explain a little bit more about it, it's structured in 5 domains with different number of items in each of those domains, so that the information, care and treatment, organisation, parental participation, and professional attitudes. And in addition to those the 30 items, there's a capacity for parents to provide written feedback, and so that can be very useful for very much richer data than response to the items that are on a 1 to 6 Likert type scale. So this gives you an example of how you can use those domains, the 5 domains, and in this example they're in Dutch, but information, care and treatment, organisation, parental participation, and professional attitude. And this spider chart shows the results of the 7 PICUs in the Netherlands, and identifying individual units against a group performance. So for empathic 30 Oz, when we decided to translate and validate the empathic 30 in the Australian context, we also considered that the questions were suitable for a broader context, so not only paediatric intensive care, but also in the neonatal setting, and the more broad, again, paediatric ward setting. So our objectives were to translate into the English Australian language, culturally adapt, and also test the questionnaire in these settings, and then also undertake some preliminary measurement of the perceived care in these areas to look for opportunity for improvement. So the translation and cultural adaptation process took the formal structured 10-step process reported first by Wild and et al, and has been undertaken by many of the surveys in the same way. And then our validation settings were in 2 hospitals, so in the Children's Hospital in ward settings, so in a specialty burns unit, a surgical ward and a medical ward. The paediatric intensive care unit in the Children's Hospital, and then the neonatal unit, which encompassed neonatal intensive care, but also included level 2 and level 1 nurseries in the Women and Newborn Hospital. So for this validation study, the sample was a convenient sample of parents who could speak English and whose child or babies stayed in the hospital for a minimum of 24 hours, and the sample size calculation was just over 100 responses per setting. So this was back in 2014 and was not funded. So our questionnaires were distributed by clinical nurses and midwives, hand distributed, so hard copies, during the discharge process. And then completed questionnaires were collected and returned to a collection box before the patient was discharged from that setting. Our analysis focused on reliability, so internal consistency using Cronbach alpha, congruent validity against 3 gold standard scales, which I'll explain in a moment, so using Spearman's rank correlation, and non-differential validity using some of the characteristics. And then we also compared differences between the groups. So for some results, the characteristics of the sample, we had around 100 in each group. The length of stay was, for the neonatal unit, was nearly 23 days, for the PICU just over 2 days, and for the ward areas nearly 7 days. Mainly the questionnaires were completed by mothers. Mainly the patient had been admitted in an unplanned admission. Those that had English as a second language was overall less than 15%, mainly Australian born. And for those children who had been in the PICU, just over half of those had been mechanically ventilated. So reliability testing was adequate with the Cronbach alpha at the domain level of at least 0.7. For the congruent validity, measured against 3 gold standard statements that you'll be familiar with, I would be happy to return to this unit or ward. And then overall satisfaction with the performance of doctors, and then overall satisfaction with the performance of nurses. And there was adequate correlation with these overall satisfaction statements. For the non-differential validity, there was no significant difference between the mean scores of the domains and the participant characteristics of being a planned admission, English as a second language, and parent born in Australia. So we were able to demonstrate that we successfully translated and culturally adapted the empathic 30 Rs as a reliable and valid questionnaire for both, or not for both, but for all settings. So for the paediatric critical care, the paediatric ward setting, and neonatal ward setting in the Australian context. So when we went on then to compare some the responses between the different areas, you can see how we also have been able to show that this is quite a really good visual representation of the results at the domain level. So the scoring for the items is between 1 and 6, so 6 being a maximum score, and we've got the domains around the outside, so information, care and treatment, organisation, parent participation and professional attitude. And you can see how the neonatal unit is in blue and the wards red and the PICU is in green. So the PICU overall performed really highly. The areas for improvement are quite clear there, that for the ward areas, the area for improvement is for organisation. And then for the neonatal unit, 2 areas that showed up for improvement during this study were for care and treatment and for information. So at the domain, at the item level, it gives you some examples of some of the statements overall performing. So remembering it's a maximum score of 6, the overall mean scores highly. So this shows the how you can look at the different items, and so the comfort and well-being of our baby was taken care of by the nurses, performed the highest. And then some of the lowest responses were, remembering this is the overall sample, so the very lowest was that every day we knew which member of staff was responsible for our child or baby. And then if our intention is to improve the quality of care, then adding in the narratives of parents can add really a richness to our findings from the survey. So this is a thematic analysis that we undertook at the time in the neonatal unit. So to identify the key issues that parents identified, and it could be presented in a visual way with quotes to really show the richness of the data. So in summary, empathic 30 Oz can be used as a standard parent-reported experience measure. There is an opportunity to use this questionnaire as a framework for quality improvement, so to measure parents' experience in PICU and indeed throughout their hospital stay. It can be an outcome measure for family-centred care interventions, and a number of countries are using the empathic just like that. For example, the Netherlands has been nationally measuring parent-reported experience since 2014. And other countries have also been developing the empathic as a parent-reported experience measure on a bigger scale, so nationally as well. And then, as you may be aware, that the ANZIC's PICU registry has a group have agreed to adopt the empathic as a parent-reported experience measure from 2023. So that will now be added to the ANZIC's core registry data, and so that will enable both national and international benchmarking. Thank you.